Hello, everyone, and welcome. Thank you so much for joining us today. Reggie, I think we can kick things off.
Great. Well, welcome everyone to our next session, which is Minding Gaps in Healthcare and Social Care. And my name is Reggie Tucker-Seeley, and I will be the moderator for this session. And I'm also joined by a discussant who is Stephanie Walker. So a little bit about me, I am the Vice President of Health Equity at Zero, the End of Prostate Cancer, which is a prostate cancer education support and advocacy organization. So, and we have, as I mentioned, we have a discussant for this session, Stephanie Walker. So Stephanie, would you like to introduce yourself?
Hi, my name is Stephanie Walker. I'm a metastatic breast cancer patient. I consider myself a patient expert. I do have my PhD in that. So I'm here to learn just like you guys and to encourage conversation.
Great. And thank you so much for joining us today, Stephanie. So we have 3 speakers for this session. Each will have 10 minutes to present. We have Alexis Cacioppo, we have Eva Shiu, and Laura Samuel. So we have agreements for a safe and brave meeting. Specifically, they're all listed here, but one that really stands out is that we respect each other's differences and background. And another one is that we agree to disagree, but that we seek understanding and we are here to learn. So there are 3 ways to engage in the room. One is the chat window. So if you have questions, you can put them in the chat. You can also use your emoji reactions if you want to raise your hand to ask a question, or just to give a thumbs up to a comment or claps to a comment that's made. Feel free to keep your camera on during the session, but please mute to avoid background noise. And please do follow us on Twitter using the hashtag #SirenRacialEquity, and also follow us at @Siren_UCSF. So now I will turn it over to our first speaker, Alexis Cacioppo.
Hi, I'll just take a moment to share my screen. And can everyone see and hear me? Okay. Hello, everyone. My name is Alexis Cacioppo. I am a 3rd-year medical student at the University of Chicago Pritzker School of Medicine, as well as a research collaborator with the Lindau Lab at the University of Chicago. I'd like to acknowledge my funders and have no conflicts of interest to report. Food insecurity, defined as having limited or uncertain access to adequate food, is a significant health-related social risk for children and their parents and caregivers. Food insecurity disproportionately affects households with children, those who identify as African American or Black, and people living in poverty. In recent years, a number of children's hospitals have implemented system-wide protocols for routine assessments of food insecurity and referral to community-based food assistance resources, as recommended by the National Academy of Medicine, the American Academy of Pediatrics, and the Children's Hospital Association. However, in light of data that feelings of discrimination while connecting to food assistance can deter resource use, we wondered how food security status relates to parents' experiences of discrimination in the children's hospital setting. We hypothesized that parents with food insecurity are more likely than those without food insecurity to experience hospital-based discrimination during their child's hospitalization. To test this hypothesis, we analyzed survey data obtained from the control arm of the Community RX Hunger Trial, a double-blinded, randomized controlled trial of an intervention that aims to screen for and intervene on food insecurity among families with a hospitalized child. From November 2020 to May 2022, we recruited parents and caregivers during their child's admission to the general inpatient and intensive care units of an urban academic children's hospital. Eligible parent participants lived in a 32 zip code region and self-identified as the primary caregiver of a hospitalized child. Parents and caregivers of well newborns, children expected to be hospitalized for less than 24 hours and more than 30 days, and patients 18 years or older were excluded from this study. After obtaining informed consent, we enrolled eligible parents and caregivers in the trial and surveyed participants in the hospital at baseline and 1 week after their child's discharge. This study focuses on the control arm of the trial, as the Community RX Hunger Trial is still collecting follow-up data. Our survey instrument queried 2 domains: 30-day food security status, and hospital-based discrimination, using items from validated survey tools. 30-day food security status was assessed by an interviewer in the hospital on a scale of 0 to 18. Raw scores were then split into 3 food security statuses: food secure, marginally food secure, and food insecure. Meanwhile, hospital-based discrimination was measured using the DMS scale 1 week after discharge. Each item on the DMS has a raw score of 1 to 5 on a Likert scale. The sum of each item on the DMS is calculated to gather the overall DMS score ranging from 7 to 35. For this measure, higher scores indicate more frequent experiences of discrimination. Moving on to the analysis, linear regression models were performed in Stata with food security status as the independent variable and overall and per DMS score as the dependent variable. Unadjusted models were run, followed by models adjusted for race, income, gender, and marital status, variables known to be associated with food insecurity and discrimination. Additionally, participants who did not complete all relevant items were excluded from our analyses. Overall, our sample of 301 participants were largely mothers in their mid-30s who identified as African American or Black and were partnered. Regarding food security status, 1 in 4 mothers surveyed were food insecure and 1 in 6 were marginally food secure. Additionally, most participants had an annual income less than $50,000, were publicly insured, and lived in households receiving government nutritional assistance. Here we show the frequency of hospital-based discrimination reported on each of the 7 DMS items by food security status. The y-axis lists each DMS item, and the x-axis specifies the percentage of participants. For each DMS item, the 3 horizontal bars on the right correspond to each of the 3 food security statuses on the left. Within one horizontal bar, the length of each segment corresponds to the percentage of mothers in a given food security status who responded never, rarely, sometimes, most of the time, or always, as denoted with different colors, to each of the 7 DMS items. In this graph, the length of the yellow bars, corresponding to the response of never, indicates that few mothers ever experienced discrimination during their child's hospitalization. However, comparing the sums of the green, teal, blue, and purple bars for a given DMS item demonstrates that there's great variation in the frequency of hospital-based discrimination experienced of mothers by different food security statuses. Adjusting for baseline characteristics, mothers with food insecurity experienced more discrimination in the hospital than mothers without food insecurity, scoring on average 2.5 points higher on the overall DMS score. This relationship was statistically significant and was driven by differences in the frequencies that mothers with food insecurity reported feeling like their doctor or nurse was acting as if they were better than them or afraid of them, as well as being treated with less respect and less courtesy during their child's hospitalization compared to their food secure counterparts. Results that compared DMS scores between mothers from marginally food secure and food secure households are not shown, as only one of these comparisons was statistically significant. To summarize, I'd like to highlight a few key findings from this study. First, more than 1 in 4 parents of a hospitalized child hospitalized during the COVID-19 pandemic, mostly lower income African American and Black mothers, lived in a household that was food insecure. Without access to sufficient food, a child may not be able to adhere to medication regimens, healing can be compromised by poor nutrition, and caregivers may struggle to make critical caregiving decisions and other medical decisions for their child. Second, while few mothers in our sample indicated ever experiencing hospital-based discrimination, there was great variation in the frequency and type of hospital-based discrimination experienced by mothers of different food security statuses. And third, food insecurity in the last month was positively and independently related to more frequent experiences of discrimination for mothers of hospitalized children, supporting our hypothesis. That said, our findings offer evidence for the integration of anti-discriminatory practices into hospital-based efforts to screen for and intervene on food insecurity. Practices that support caregivers in feeling like they are respected, treated with courtesy, and viewed as equals by their healthcare team may mitigate feelings of discrimination in hospital-based screening and intervention and promote food assistance use. Our results also demonstrate the potential of the DMS scale as a tool for social care researchers and practitioners to measure discrimination experienced in the setting of food insecurity screening and intervention, development, and evaluation. The limitations of our study fall into 3 categories. First, our study was designed before the COVID-19 pandemic. As such, data were collected during a time of national reckoning around issues of racism, discrimination, and injustice. To this end, our findings related to food insecurity and hospital-based discrimination should be considered within these contexts. Second, our single site design, relative homogeneous sample, and use of data from a randomized controlled trial may limit the generalizability of our results. Third, this study assessed experiences of discrimination using broad measures that bundled the complex and often intersecting forms of marginalization experienced by food insecure households. Further research is needed to pinpoint the root cause of the hospital-based discrimination triggered by food insecurity. Thank you for your attention, and I'm happy to take questions in the chat or after.
Great. Thank you, Alexis. Our next speaker is Eva Shiu.
Thank you. I'm going to take a moment also to screen share. All right, can everyone see the screen okay? Excellent. Hi, my name is Eva Shiu, and today my presentation is about health-related social risks experienced by East and Southeast Asian women during the COVID-19 pandemic. I'll be presenting research from a paper first authored by Dr. Milky Vu, and the co-authors on this paper are also found on this slide. I have no conflicts of interest to disclose, and I would also like to acknowledge funding support from the National Institute on Minority Health and Health Disparities, as well as support from the National Institute of Aging, both of which fund the Community RX program of research. In the early pandemic phase, we found that nearly half of US women, 49%, experienced new or worsening health-related social risks. This includes almost 30% of women who reported having no pre-pandemic health-related social risks. And we saw that the pandemic has had substantial impacts on US women, both economically and socially. Because of the initial findings from this paper, we thought it was important to take a closer look at health-related socioeconomic risks by race and ethnicity, and I'll talk about the findings in subsequent slides. Before we jump into the research, I want to paint a picture of the landscape back in March of 2020. There was a rise of anti-Asian sentiment, especially after then President Trump referred to the pandemic as, quote, the Chinese virus. There have since been countless examples of East and Southeast Asians experiencing racism, discrimination, and victimization from targeted acts of violence. We saw this in the news headlines, spanning from the East to the West Coast and everywhere in between, including Atlanta and Chicago. One of the researchers who studied anti-Asian sentiments on social media described how, when using race to describe a virus, it is not only hurtful, but can have a downstream impact on those who are Asian or Asian American. So what are the effects of the COVID-19 pandemic on East and Southeast Asian women? And what are the factors at play here? I'll define the 5 domains of health-related socioeconomic risks, which I'll refer to as social risks going forward. We looked at 5 policy-relevant domains, and they are food insecurity, housing instability, transportation difficulties, utilities difficulties, and interpersonal violence. These social risks are poorly understood among East and Southeast Asian women. The Asian subgroups in our research sample comprised of Chinese, Filipino, Japanese, Korean, and or Vietnamese women. These 5 Asian subgroups were also the most frequently targeted in early pandemic-related discrimination. You'll hear me refer to these subgroups as Asian women going forward. Social risks are also poorly understood, in part due to stereotyping and the model minority myth. This myth is defined as the perception of high academic and economic achievement among Asian Americans. It's a concept rooted in anti-Blackness through the false proximity of Asian Americans to whiteness, as defined by Wong and colleagues in 2006. This myth has been used to deny the existence of institutional racism and to pit minority groups against each other, and to uphold the narrative of white supremacy as defined by Kauai in 2005. So painting the landscape and then moving on to the research, the 2 aims of this study were to examine the patterns of change in social risks in the early pandemic by race and ethnicity by focusing on East and Southeast Asian women, And the second aim is to fill the gaps in our understanding of pandemic-related changes in social risks among Asian women to ensure an equitable and informed approach to pandemic management and recovery. Participants were recruited from OP4G, a national research panel, and we oversampled East and Southeast Asian women with a total of 3,200 women completing the survey with an 88% cooperation rate. Participants received an online survey link and completed a self-administered web-based survey. Social risks were assessed using the Accountable Health Community Screening Tool. We asked about absence, presence, and change in social risks since the start of the pandemic. For the study, we define early pandemic as the 2-month period starting with the World Health Organization, the WHO's declaration of the COVID-19 pandemic in March 11th of 2020. The pre-pandemic period in this study is the time before the WHO's declaration. And social risk status in pre-pandemic period was assessed retroactively. This slide shows rates of prevalence in social risk in pre-pandemic and early pandemic by race and ethnicity. And you'll see a table of the colors by race and its ethnicity at the top right corner. Prevalence here is defined as the total number of individuals in our sample reporting a social risk at a given time, expressed as a percentage of the population. For example, looking at the first panel of food insecurity, it was one of the most common pre-pandemic social risks across racial and ethnic groups. Pre-pandemic rates of food insecurity were 45% higher for Asian women compared to 33% of white women. Here, early pandemic prevalence rates of social risks were higher than pre-pandemic rates. So if you look at the columns in early pandemic on the right side versus the left of each of the domains. The racial and ethnic differences in early pandemic prevalence rates were significant for all social risks. And I'd like to draw attention here specifically to the Asian line represented by light blue in transportation difficulties from pre-pandemic to early pandemic, and also in interpersonal violence from pre-pandemic to early pandemic. This slide shows rates of new and worsening social risks by race and ethnicity. Rates of new risks are on the left, incident/new reported risks, and are indicated by the circle symbol, and worsening risks are indicated by the triangle. Rates of worsening food insecurity, for example, on the left, were very high among all racial and ethnic groups, as were rates of interpersonal violence. I also want to draw attention to the rates of worsening transportation difficulties, which were 20% higher for East and Southeast Asian women than for every other group. And just take a look at this blue triangle up here. For Asian women, it was 78%, for Black women, 63%, for white women, 60%, and for Hispanic women, 49%. Many people have pre-pandemic social risks, even more had early pandemic social risks, and we see across the board worsening social risks during the pandemic. The main takeaways from this slide is that compared to white women, using that as the reference group, Asian women had higher odds of having at least one pre-pandemic social risk with an adjusted odds ratio of 2.2, which is statistically significant. And any numbers here that have asterisks means that it was statistically significant in our findings. Asian women also had 2 to 3 higher odds of food insecurity, transportation difficulties, and interpersonal violence. Moving to this rectangle in the middle here, Asian women had higher odds of experiencing new or worsening social risks in the early pandemic at 1.6. They also had higher odds of experiencing new transportation difficulties at 3.6, and an adjusted odds ratio of 2.5 for experiencing worsening transportation difficulties compared with white women. These Venn diagrams here illustrate the co-occurrence of social risks comparing white women on the left to Asian women on the right for the 10 most prevalent social risk combinations by ethnic group. Other than food insecurity, most other social risks were experienced in combination with another. The most common comorbid or overlapping social risks was food insecurity with transportation difficulties. And visually, you can see this as the overlapping surface area here on the circles on the left side and on the right. 10% of Asian women had food insecurity and transportation difficulties compared to 6% of white women. And overall, 1 in 28 Asian women experienced all 5 social risks, which is an indicator of disparities and vulnerabilities in the extreme. So taking all of that in, what are some of the patterns, gaps, and limitations and implications for research? We see that health disparities exist across the board for different racial and ethnic groups, especially for Asian women in our sample during the pre-pandemic and early pandemic phases. Asian women experienced higher rates of new and worsening transportation difficulties. And 1 in 28 Asian women experienced all 5 social risks compared to 1 in 100 white women, which is an indicator of disparities and vulnerabilities in the extreme. Some gaps and limitations. The data collected for this group has been scarce. And because these estimates were generated in the first several weeks after the WHO's declaration of the pandemic, these are likely a conservative indicator of later pandemic conditions. We see that the model minority myth can perpetuate a stereotype that Asian women do not experience social risks nor have vulnerabilities. And compounding factors of the pandemic and anti-Asian sentiment has exacerbated social risk vulnerabilities for this group, especially with the rise of experienced violence or fear of violence in the communities where they live. Another note is that transportation happens outside of the home, and sometimes food insecurity is impacted by being able to travel to get food. Some implications are to take a closer look at racialized stereotypes and data quality, which shape the health of Asian women, and to continue to study changes in health-related social risks by race and ethnicity, and a call for the disaggregation of data. I'd like to acknowledge Dr. Milky Vu, who is the lead author of this article in the Journal of Women's Health. A special thanks to her, as well as Dr. Jennifer Mikularski, Dr. Stacy Lindau, for their feedback and support on this presentation, and a note of appreciation and shout out to members of the Lindau Lab. Thank you so much.
Great, thank you, Eva. And so if you have any questions, please do put them in the chat. I'm writing them down to make sure that I have them all at the end so that we can ask your questions after we hear from our discussant. So our next speaker is Laura Samuel. And I think there was a question about whether or not you should keep your cameras on. Feel free to keep your cameras on during the presentation for the audience.
Hey, you folks. Sorry, I'm just having some trouble sharing my. Oh, am I sharing my screen? And I don't see it. Can
We
you
see your screen.
Yes.
Okay, good. Okay. It looks different in this view than in the view I'm used to. Okay. So let me go back to the beginning. So thanks, everybody. Those are such great presentations. It's been terrific to hear really thoughtful discussions, and I think they align with what I'm about to talk about also. So I look forward to the discussion of all three. So I'm going to talk a little bit about the role of SNAP as it relates to racial equity of food insecurity in the United States. And so here we're looking at the intersection of race and food insecurity and SNAP participation and utilization. And I want to give a lot of thanks to the co-authors that you see listed here. So just as a bit of background, we know that in the US, Americans who are Black have higher rates of food insecurity than those who are white or Asian typically, even after accounting for underlying income inequality. And this has persisted over time, and there's also some evidence to show that it worsened during the pandemic. And although we know that SNAP typically reduces food insecurity, there hasn't been a lot of attention paid to whether SNAP access could actually work in a way that would reduce racial inequalities. And so I'm especially interested in whether SNAP not only improves food insecurity broadly, but whether it reduces this racial equity gap with regard to food insecurity. And so to examine this, we use data from the 2018 survey of income and program participation. So this is before the pandemic. This was an annual survey. That's a national survey. It's actually used by the USDA to track utilization of SNAP and other food assistance programs. And we analyzed households rather than individual people because SNAP is a household level benefit and because food insecurity also occurs typically across a whole household, not just for individual people. And so we focused our analyses just on the subset of people who would be eligible for SNAP based on SNAP's federal guidelines. So that includes people with incomes that are less than or equal to 130% of the poverty threshold. So these are basically all people who are at or below or near the poverty threshold, a low income group. And we measured, well, SIP at least, measured food insecurity using a well-validated tool from the USDA. We categorized household racial composition according to whether everyone in the household identified as Black, everyone identified as white or Asian, and then there was kind of a group of households that either included multiracial individuals or people of multiple races in one household. And we looked at SNAP use in the past 12 months as just yes or no SNAP use for that household. And so this is just kind of a graphic to show overall the rates of food insecurity and SNAP participation rates. And so you can see, comparing across different racial groups along the bottom axis here. And what I want to draw your attention to are the differences in the prevalence of food insecurity among households that were either all Black or multiracial households compared to households that were white or Asian. And so what we see here is kind of, different groups according to both food insecurity and SNAP participation. So the dark gray group are people who are food insecure and already on SNAP. And then the dark blue group are people who are food insecure but not participating in SNAP. And you can see for both of these groups, the percentages of households that are either Black or multiracial are higher than the percentages that you find in the all white or all Asian groups. So suggestive of disparities in terms of overall prevalence of food insecurity, regardless of whether someone is participating in the SNAP program. And so we then ran regression analyses. So here we're looking at the prevalence rates of food insecurity among these US households and comparing different households based on their racial identity. And so you can see overall in the sample that households that identified as either all Black or multiracial had a higher risk of food insecurity compared to households that were white. And we actually see that households that were all Asian actually in this case, and again, this is admittedly before the pandemic, had overall at least a lower risk of food insecurity. But then we wanted to know what was the role of SNAP, remember, right? So can SNAP participation reduce these disparities in any way? So we grouped people according to whether they already were participating in SNAP or not. And so among the people who are not participating in the SNAP program, we found evidence of racial disparities. Specifically, households that were all Black had a 47% higher risk of food insecurity compared to households that were all white. and households that were multiracial or composed of multiple people of multiple racial groups had a 31% higher risk of food insecurity compared to households that were all white. Then when we looked among households that were receiving SNAP benefits, we actually didn't find evidence of any racial disparities in terms of food insecurity risk. So to kind of summarize these findings, we did find evidence of US racial disparities in food insecurity risk, focusing on a low-income population of adults and households that do not participate in the SNAP program. But we didn't find evidence of disparities among households that do participate in the SNAP program. Now, we could kind of draw two different conclusions based on these results, right? So keep in mind, this is a cross-sectional study, so it just really provides us with a snapshot in time of what's happening. And we don't know, importantly, whether some households might have enrolled in SNAP because they were food insecure. And we likewise don't know whether SNAP participation actually reduced food insecurity over time, because we're looking at things at just at one point in time. And so it's possible that these results are due to the fact that the SNAP program is able to reduce food insecurity. And as I mentioned at the beginning, there is good evidence from other longitudinal studies to suggest that SNAP can reduce food insecurity. But it's also possible that that there are race-based barriers to, sorry, that's a typo, race-based barriers to SNAP participation for Black households with food insecurity, specifically that there could be some households that are food insecure and may benefit from SNAP, but face specific structural barriers to the enrollment process. And the SNAP enrollment process, admittedly, is rather cumbersome. It typically involves an application, which could be done online or in person, sometimes involves an interview, usually requires someone to document their income and other household characteristics. And so there could be some aspects of that enrollment process that kind of disproportionately affect certain communities that might result in racial disparities. So this study certainly has some strengths and limitations. We relied on a national survey, which allows us to draw conclusions about the US population, and we have very good measures of food insecurity, but it is limited in the way that it's cross-sectional. So we can't, it becomes a chicken and the egg. We can't conclude that SNAP participation actually reduces food insecurity in this population. But overall, I think it has some specific implications nonetheless as we continue this discussion of food insecurity and addressing social needs. One is that, there have been growing calls for universal screening for food insecurity. This is recommended both by the Centers for Medicare and Medicaid and by the recent White House and their national strategy for addressing hunger and nutrition and physical activity. And certainly greater screening for food insecurity could conceivably at least help address health equity gaps in terms of referring people for SNAP and other food assistance. And this study suggests that greater screening and referral might be useful. But research is still needed to really make sure that the SNAP eligibility criteria, the enrollment process, and the SNAP recertification processes are all really equitable in terms of ensuring that everybody who's eligible for this program has an equal chance of actually receiving the benefits to which they are entitled. And then really a lot more research is needed to address broader issues of structural discrimination and racism in communities that result in differences in terms of food affordability and access to food, which things like food deserts that might also be shaping risk of food insecurity. So in acknowledgement, I want to give gratitude to the funding for this research, and I'm happy to take any questions.
Great. Well, thank you, Laura, for that presentation. And thank all of our presenters for outstanding presentations today around social needs. And so now I'll turn it over to our discussant, Stephanie Walker.
Those are some great conversations, but I had a couple of questions, and then I'll give it back to Reggie that there were several good questions in the chat. One of the things that I kind of like focused on was that the food insecurity of hospitalized children. I just can't get over, and I noticed that it was in Chicago. It's probably a bigger hospital, but how are these children that you noticed this in the hospital? Is there any kind of follow-up or anything when they go home to find out if they go home to a worse situation, that's not even a word, a worse situation, or a situation that may be improved because someone noticed that they had this food insecurity and mom was able to apply for some kind of assistance to help at home?
Hi, Stephanie. Thanks for your question. So I guess in the usual care in the pediatric hospital that we conducted this study, patients are connected with a patient coordinator, patient navigator, and this is someone that helps like the patient and in their families in the context of pediatric care kind of fill the social needs that they have that have been identified in the hospital. But I agree with you, that's going to be really important. If we identify that a family is food insecure, there needs to be some mechanism to follow up with them and make sure that our efforts to connect to them to resources actually worked.
Definitely. Having worked in that space before, it's very noticeable. Also, another question that I have for Eva regarding transportation. Why in the world? I mean, it boggled my mind to see that there was such a huge flip or a difference in transportation with Asian women after the pandemic, or I mean, was it after or during the pandemic?
We saw cases of new instances of difficulties and worsening, and there was really high rates of worsening transportation difficulties, which means they did experience them before the pandemic. And I think there were just lots of factors at play. The model minority myth, anti-Asian sentiments and discrimination as a result of COVID-19 and the association of that with Asian Americans or Asians. And so a lot of those compounded can contribute to, say, a person being afraid of experiencing interpersonal violence when they leave the home. That can be connected to taking public transportation to where they need to go. It could be connected to the public transportation to get to food.
Right.
So a lot of these domains are actually related. And so there are just a lot of factors at play that contribute to new cases and also the worsening of existing cases. And I think a lot of this is also connected to limited data. Data was very scarce in this population.
I noticed that, very much so.
Yeah.
What do you think can be done to increase that? I mean, seriously, it is, I realize that they do have the disparities as well, but how can you encourage the Asian population to be more, I don't know, forthcoming with their concerns, problems, issues surrounding socioeconomic problems?
Yeah, I mean, the answer to that, it would be amazing if it was very easy.
Along with the lottery numbers too, right?
Yeah. I think there's two places. One is in research, and the other is programmatic in connecting people in their communities. So it's maybe twofold, maybe threefold, fourfold, but it involves many different players, including researchers, including people in the community health workers, even people kind of talking about the fact that people are experiencing discrimination and the effects of it. So I don't have one clear, easy answer.
Right, I understand.
A lot of more attention, more resources, and putting it at the forefront of people's minds, especially when talking about the Asian population in research, will start to move the needle.
Yes, ma'am. Reggie, I know you have a lot of questions.
Yes, so thank you, Stephanie, for kicking us off there. Again, outstanding presentations. And so for those of you who put questions in the chat, I've pulled those out, but I'll start with I'll take my moderator prerogative to ask my own first questions. So my first question is for Alexis. So Alexis, why adjust for race? It seems that 81% of your sample was African-American. So could the story that you tell here be about the discrimination that Black patients experience when they are navigating the healthcare delivery system?
Yeah, Reggie, that's a really good point. I think for this analysis, we were hoping to adjust for race to account for the racial diversity of our patient population in our hospital. And I agree that like doing further analyses where we looked at the experiences of hospital-based discrimination by racial group in our sample would be really interesting.
Yeah. Please. And then my next question is for Eva. So you mentioned multiple Asian groups that were included in your sample. And so was there any, or I missed the slide around sort of sample size. So did you have enough to do sort of intra-group evaluation to determine whether or not there were differences across the Asian groups that were included?
We aggregated those groups to make up East and Southeast Asian. I think it would be amazing in the future if we had more folks in those groups that we can disaggregate even further. But in our sample, we oversampled for folks that identified as East and Southeast Asian, because there were not as many of those subgroups in our analyses.
And then my last question, I think, Laura, actually, you touched on it a little bit in your last slide, but I was trying to sort of get at, or thinking through, what is the mechanism that SNAP is actually addressing that eliminates that difference across racial and ethnic groups? So you see it in those that aren't on SNAP, but then it goes away for the SNAP participants. What are the mechanisms that are at play there that help to eliminate that difference?
Yeah, that's a great question. I think, all SNAP really does is provide money for food, right? It's a very targeted assistance program. And so, I think it's useful in that it improves the affordability of food, which then admittedly can make a big difference, because if somebody's choosing between heat and food or housing and food, they might be more able to afford other basic needs as well. But admittedly, it still is limited, right? It's not going to address, say, like transportation to get food, or some of the other things that might also be barriers to food insecurity. And I think we have to acknowledge that, racism is so pervasive that there are many mechanisms that contribute to racial disparities and food insecurity. And SNAP is probably just one piece of the puzzle.
Yeah. So I noted that someone put a question in the chat for Alexis. What kind of qualitative data would support your work? And I note that Alexis, you put some studies in the chat, but if you'd like to, I'd like to give you a chance if you'd like to provide any additional context for that question or answers for that.
Yeah, Yuri, I really appreciate your question. I think in conducting this study, I referenced several of the qualitative studies that I've linked in the chat, which have examined the perspective of parents and caregivers in different pediatric healthcare settings like clinics or hospitals or emergency rooms. And it seems like in general, parents and caregivers want screening experiences and connections to community resources that make them feel valued, that make them feel safe. Especially there's a concern among parents that if healthcare providers find out that they're not able to provide food for their children, there's concerns that DCFS might get involved, and that or other like legal issues for folks that are undocumented. So in general, it seems like screening and intervening efforts should be safe, destigmatizing, and offer as many opportunities for connections to care for these parents. But those studies are really great that I've cited.
And you raise a really good point. I think for communities who have either historically been discriminated against or marginalized by the healthcare delivery system, the expectation that they are going to be very forthcoming with issues that they may perceive could could one, jeopardize any other aspect outside of the healthcare delivery system, but also that could potentially impact the care that they get as they're navigating care. It definitely impacts whether or not one offers that information during screening. Another question that was raised that's for Eva, this notion that food insecurity questions might be stigmatizing. So would universal screening help destigmatize food insecurity screening and sort of encourage more people to offer up this information?
Yeah, I think that's a good, oh, is that for Ava? Sorry.
Yeah, it was for Ava, it was for Ava, but Alexis, I'll come back to you if you have a response for that as well.
I mean, I think universally providing anything would destigmatize since it's offered for everyone, especially at the point of care. You know, like addressing food insecurity and screening at hospitals is a good place to reach people, because lots of times it's even how do you reach folks too if it's not in their homes, if it's not, you know, a community program. One good place to do it is at the point of care. So I personally am a fan of universal screening and think it has, you know, can lead to tremendous benefits for people. And when it's done mindfully and, you know, with considerations.
Yes, to that last point, when it's done well and with consideration. I think, you know, I work in the cancer space, and so thinking about, you know, when across the cancer continuum as people are navigating care, do we ask these questions around social needs? Great point. So the last question, we're about to wrap up here, but I have a question for Laura, which I think raises a really good question around who is our reference group when we're doing work around health disparities. So the question for Laura is, on the one hand, you'd want to take Asians as your reference group because they were the biggest percent food secure, but they're the ones who flip the proportions to become then the most food insecure. So how do you make decisions around who is your reference group in the work related to disparities? Because oftentimes we want to think about the group that has the best rate, shows that rate is attainable. So that should be our reference. So can you talk a little bit about sort of your decision-making process in terms of who's the reference in your food insecure work?
Yeah, thanks. That's an excellent question. And I'm really glad that Eva also presented in this session. So I think, you know, my results only show one part, right, of the picture, but I think that might suggest that Asian Americans are doing relatively well, but clearly, you know, they're not. And so I think that's an excellent point, and you could just as easily, you know, use Asian Americans as the reference group in our analyses. I focused on whites largely because they are a group who also have relatively higher participation rates in SNAP. And so we wanted to have kind of just like decent numbers of people to compare across each of those four groups. You know, we're looking not just at SNAP, and we're looking at SNAP and race, and wanted to make sure that we had adequate comparisons. But I can tell you that we also have looked at Asian Americans and similarly find Black versus Asian American disparities as well, if that's useful.
Great. So we are right at time. So I want to thank all of our speakers and our discussant, Alexis, Eva, Laura, and Stephanie for a fantastic discussion. Thanks to you, for those of you who put questions in the chat. And I hope we continue to have a great meeting today. Thank you very much.
Thank you.